So anyway, the case studies are done. Fabulous job, very impressive. Obviously, with the final product that you guys submitted, you worked very well as a group, and I'm really proud of that. Really proud of that. So great job. Okay, that's case studies. As far as exams, if you score below a 78, I am required to do what's called an at-risk report. Okay, and those are I have to submit paperwork every Monday to your dean. It says so-and-so Kathy Marvel has a 76. She attended a review session. She didn't attend a review session. We're going to meet. I reached out to do tutoring. She's responded. We've already met, or we haven't met yet. She hasn't responded. Anyway, we're required to do that. So I only tell you that is because if you're one of those students that are below a 78, I don't want you to be surprised when your dean contacts you, if they do, to say, hey, how come you didn't go to a review session? Hey, next exam, go to a review session, or it looks like your instructor offered some times to review the exam. You should take advantage of that. Those kinds of things. I just don't want you to be surprised. Okay, so that's my at-risk reports. Today we're going to cover weeks 3 and 4. Oh, I want to go over a couple of assignments with you. I want to go over your second group assignment, which is due in week 7, and your vulnerable populations due in week 9. As far as exam 1, I offered numerous times over the weekend. I know people work on the weekend 7 to 7, but I did offer times at 8, 9. I mean, I tried to be as flexible and meet your needs. I didn't have that many takers. I mean, I did have some, and it's great. But if you're below a 78, my suggestion is you really should review the exam and see where you went wrong. And even if you're, I met with a student in another class over the weekend that had a 94, and she wanted to know the 3 questions that she got wrong, and she wanted to go through the rationales. So I can meet with anybody, but you got to take advantage of it. Oh, Monica, there's that little baby. I have one of those. Not really me, but in the family now. So anyway, that's exam 1. Study guide 2 is coming, hopefully this week. Exam 2 covers weeks 3, 4, and 5. So we're going to cover 3 and 4 today. We'll do 5 next week. And then remember, we're already at week 5 next week, which is at the end of week 5, we do review sessions for exam 2. Okay. That's it. Before I share my screen, do you guys have any burning questions that you want to cover? Anything we need clarified? I'm going to share my screen. I want to cover a couple of things here before we get going. Okay. First, let's just cover this. I'm assuming that if you haven't contacted me, that you're not having any issues getting into the hospice HESI case study. I already see some scores popping up. Just so you know, it is due Sunday. I know it says a due date. I had to push it out to the 15th. It's a week later. Here's why. It is due on the 7th, right? Sunday's the 7th, right? Sunday the 7th. 8th. It is due on the 8th. Okay, it is due on the 8th. The reason why the 15th is in there, we always follow the modules for due dates, but I had to push it out a week because if you're late and you don't turn it in on Sunday, and I close it and I put a due date for Sunday the 8th, you can't get in. Can't get in next at all during the 7 days of that late time frame. So that's why I have to open it up to the 15th, but it is due on the 8th. So I want to be clear about that. Okay. All right. I'm already seeing grades populated with the case study. You don't need to submit anything. All right. When you're done with the case study, it populates right in the grade book. So you don't need to submit screenshots or anything like that. Okay. We'll do our live attestation today. And then for next week you have another discussion question. You have an NCLEX review. Okay. Oh, I forgot about Andres. Okay, here it comes. Okay, so that's next week. Discussion question and NCLEX assignment. And at the end of the week will be exam reviews. I didn't have great participation in my classes for exam reviews. I think I had a total of 10 students in 3 sections. So I was pretty disappointed in that. So I would, as I told you before, truly believe that attending live reviews, I've seen it term after term, increases your grades on your exams. Okay, but it's up to you. We try and get them done on Friday, Saturday, and Sunday so that you have the opportunity to attend. If you're working on the weekends, maybe you can attend on Friday. So I just mentioned that, but I was pretty disappointed in the turnout that my sections had. I usually have really, really good turnout with my students. I did not for this exam review. And to be honest, a lot of the scores reflected that. So anyway, okay, I'm going to jump to week 7 real quick because this is your second group project. I'm just introducing it now because I need you guys to do something for me this week. Okay, this is not due until week 7, so that's where you're going to find the information on it. It is your second group discussion, and it's about it's a infectious disease paper. Okay, so you guys need to go to this website. This can be found on the link in your week 7 that says infectious. Let's see what it says. Let me go back. It says group project discussion, review, and peer activity. That's what it says. So you click on that. What I need somebody to do in your group, somebody needs to take the lead and go to this website, National Foundation for Infectious Diseases, and pick an infectious disease that you guys want to cover. All right. I've already gotten several requests from my 2 classes from yesterday. I need to know by the end of the week which infectious disease you guys would like to cover. And if it's already been picked, I'm going to just say pick something else because I'd like a variety in each of the classes so that when you guys read these reports, read these papers, and do your peer comments, you can learn about different infectious diseases. Okay, so somebody take the lead in each group. Go pick something or ask your group what you want to do, and then send me an email this week. Okay, send me an email this week and tell me what infectious disease you pick. And then take a look at, take a look at it's right here, what you need to do. Okay. It's a research project on a particular infectious disease. Okay. Any questions about that?
Yes. So I have a question. So like each member of the group is doing a different title, or we just doing one as a whole group?
One as a whole group. I'm just asking for somebody to take the lead of organizing what infectious disease you're going to do between your group and let me know this week. Okay. And I'm either going to go, yep, looks great, or nope, already taken, pick another one. And you get it from that website. You get your list from that website. Okay. Any questions? Other questions? Okay. The other, Courtney, raised her hand. Courtney's hand is down. Does Courtney have a question? Okay, I'll take that as a no. Okay, I'm going to skip to week 9. Okay, this is a really important assignment. I want to introduce it this week. I know you have over a month to do it, but this isn't an assignment you can do the week before. Okay, it's called the Vulnerable Populations Assignment. It is worth 8% of your grade. This is not an assignment to not turn in. Okay, it's a research project. Okay, and this is this is not a group. This is an individual project. Okay, it's called the Vulnerable Populations Assignment. Okay, this is where you get the opportunity to pick a vulnerable population. And here we give you some suggestions because all of these are these are all in your community, whether you know it or not. They are. Okay, they're in all of our zip codes. So this is giving you the opportunity to select a vulnerable population. This is a list of suggested vulnerable populations. If you want to go off the grid and do something else, just let me know. That's fine. But the purpose of this is to select a vulnerable population within the community that you live in. Okay, so if you're selecting homelessness, I want to know, let's say I'm in Denver. I need to do my research paper on homeless in Denver. Okay, I need to collect demographics. I need to collect the health risks, what's available, what's not available. Okay, does that make sense? It's not, I don't want to get and it's done in a PowerPoint. You present it in a 10-slide PowerPoint. I don't want to get a PowerPoint that says homelessness in the United States is at an all-time high. And it's not about the general vulnerable population of homeless.
This is so fucking hard. We have to do like 25 questions.
Sorry?
Okay, I have a question. Are we allowed to start that part early? Like this assignment early, the research and stuff for it? Are we allowed to start that early?
That's why I'm presenting it today, Addison.
Okay, I just wanted to make sure.
Yep.
I know we don't have access to all of the modules in some courses to do early.
Okay,
So
yes, of course you can. Yep.
Okay.
Remember, we talked about that at the beginning. I have no problem with you guys working ahead, but just be careful that we have two graded assignments to turn in each week. So I'm introducing this now so that you can start the research, talk to the public health department, wherever you're going to gather statistics, get on the city's website. Okay, so this is meant to be in your neck of the woods, in your zip code. Okay, so I just present that to you now. Like I said, I know you have a month to do it, but just don't, my only message is don't wait till the last minute, because you do need to collect data. And you can read through each of these in week 7 and week 9. The group paper in week 7, and this individual one in vulnerable populations in week 9. Okie dokie. Okay, so let's get talking about what we're going to cover today. So again, I've sent you the PowerPoints ahead of time in hopes that you review them for weeks 3 and 4. I'd like to pull out the important concepts and pieces of the PowerPoint and the chapter outline, and we'll review it in each chapter. Okay, so anybody have any questions before we get started? Okay, so we know that this chapter is rural health and migrant health. What do you think about when you think about rural health and migrant health? What do you think about? Anybody ever worked or know somebody that works in rural health?
I don't technically work in rural health, but when I think about it, I live out in the middle of nowhere and like I have to drive 20 minutes to see like anybody. I don't know if that counts, but
No, that counts.
as what?
What else do you guys think about when you think about rural health? What about access? Think they have specialty doctors?
Transportation.
It's very limited.
Very limited. Think they have specialty doctors, high-risk OB doctors in rural America?
No.
No. Got to travel. Okay, so let's talk about rural and migrant health. Okay, so your chapter outline, as we've reviewed numerous times already, is your PowerPoint, right? Your PowerPoint is an extended version of your chapter outline. Okay, so if you go back and flip page after page after page in your PowerPoint, these are the topics you'll see. Okay, and then we begin to add some information, limited information to the PowerPoints. Okay, just to get you started. And then we all know why I highlight objectives, right? Because at the end of each chapter, you should be able to compare, describe, discuss, define, explain. You should be able to, should be your goal. By the end of this chapter, this is what you should be able to do. Okay, so Okay, what do we think some differences are between rural and urban settings? I'll start. Access. Access is a big difference between rural and urban settings. Access becomes much more limited in the rural areas. What are some other differences, do you think? What about kids and pediatricians? Might a kid in an urban area have more of a chance of seeing a true pediatrician than in the rural areas, right? The rural may be seeing a general practitioner who may not be as experienced in pediatric issues, right? Okay. What are some population characteristics and cultural considerations in the rural community? All right, we know once again, poverty continues to be a huge problem in rural areas. Okay, and the groups, this is important to know. Who are the groups that are at highest risk for poverty in the rural areas? Okay, there's 3 of them: children, and I'm right here on page 376. So if anybody wants to follow along with me, groups at highest risk are children, minority, racial, and ethnic groups, and single parent families. Okay, and especially the single parent families headed by women. Okay, really important to know who's at risk or who is most at risk, right? The migrant community, also known as the working poor in rural areas, a lot of times they are underinsured or uninsured, right? Box 22.1, excellent information on what are the characteristics of rural life. You know, if you're asked about this on an exam and it says, what are some characteristics of rural life? Select all that apply, or which of the following is a characteristic of rural life? Be familiar with this. Okay. Much more space between residents and services. It's kind of a seasonal work, cyclical or seasonal work, right? Everybody knows everybody, informal social and professional interactions, right? Residents who are related or acquainted, lack of anonymity. That's a big issue in rural. We'll talk about that in a minute. Lack of anonymity. Everybody knows everybody. There's no privacy, right? Challenges in maintaining confidentiality for exactly that reason. More high-risk occupations. So yeah, those are some characteristics of rural life. Okay. The other thing with rural residents is they have a much more poor perception of their overall health. Okay. They're not as in tune to what's going on, right? They're not as likely as the urban counterparts to engage in preventative behavior, right? And thus they increase their exposure to risk, right? They smoke more, they drink more, they're more obese. These are just the facts, right? They're less likely to engage in physical activity, wearing seat belts, all those primary preventative activities that we have access to in the cities, almost every corner, right? We have urgent cares and medical places we can go on almost every corner in the urban areas, right? They're less likely to do regular blood pressure checks, have pap smears, breast self-exams, right? And the other thing that's significant is because of this lack of preventative behavior activity, they're going to end up with more chronic conditions. Okay. And it's a fact that the biggest concern in rural health is chronic conditions. And they list out a few here: heart disease, COPD, cardiovascular. And according to this book, nearly 50% of all rural adults have been diagnosed with at least one chronic condition, as opposed to 25% of non-rural. That's a big deal, right? And then with all these chronic diseases comes need for medical treatment, right? Rural people, another characteristic is they typically want to stay in their homes as long as possible, right? Not only are they less likely to seek medical care, but there's also fewer physicians that can see them, right? They don't want to be traveling down, let's say, to the cities. They want to stay in their, be seen in their homes as long as possible with their family around them. A lot of them have significant barriers. You know, they don't have transportation 2 hours away to the regional hospital. They don't have, can't get there. They want to care for their loved ones in their home. Home health is huge in rural areas, huge. Okay. Rural health also presents much increased risk for women and babies. Okay, we know that overall the rural populations have a higher infant mortality, or excuse me, infant and maternal morbidity rates. Right, the areas tend to have a high proportion of racial minorities, and then there's fewer specialists. You know, if you are pregnant and you become a high risk pregnancy, there's not high risk OBs in your areas. Okay, pediatricians, obstetricians, gynecologists, you usually have to travel distances to see them. Okay, and then we start to talk about how violence and domestic abuse and sexual assault are prevalent in the rural communities. Okay, and what we learn in this chapter, you can have a read at this paragraph about female victims, but what we learn in this chapter is that victims of abuse, domestic abuse, child abuse, violence, sexual abuse, they're very reluctant to come forward, right? They don't want to show up in the ER. They don't want to show up in the urgent care, right? Why? By the time they show up, it's usually a crisis level. It's an emergency. Why do you think that is? Remember, they live in a small, tight-knit community. Why are they reluctant to report violence, abuse, addiction, mental health issues? Well, the answer is that everybody knows everybody. Confidentiality is really challenged in a rural community. Everybody talks about everybody. Everybody knows about everybody. They don't want people knowing about their business. So hence they won't seek help when some of these really awful situations. Okay. And then health of the children, we already discussed. Kids in rural communities are much less likely to see a pediatrician, so things might get missed. Developmental things might get missed that are picked up in school down the road. And then mental health is a big deal. We just talked about the stress and the stress-related conditions in rural America, and mental illness are prevalent with all the stress factors going on. Economic difficulties, increased poverty, increased unemployment, right? They delay, we're talking mental health, but this is in general, delay seeking care when they have emotional problem until it's an emergency or a crisis. And here's, you know, the incidence of domestic violence, alcohol, tobacco, other drug. It's rampant in rural America. Right. And here's what I was trying to say. When people are related to one another or know each other well, they're less likely to report these behaviors. That's the key. That's the key message I want to take away. Want you to take away. Okay. Or one of the key messages I want you to take away. Okay. What are some occupational and environmental problems in rural America? Here's the most common issues related to farm workers. Okay. There's 7 of them. Please know these. Number 1 is pesticide exposure. And there's several other. Why is heat and sun exposure considered a health issue for farm workers?
Cancer.
They can get like skin cancer or
Mhm.
something like that, but it's not diagnosed
Mhm.
because they don't seek help.
And they're out in the sun all day. right?
What page is
Why,
this on?
pardon me?
What page is this on?
I am on page 379.
Okay, thank you.
You're welcome. What about musculoskeletal injuries? Why is that a common health issue with farm workers?
Fall of a tree.
Yes. What else?
They do a lot of bending. and
Bending, lifting.
pulling, lifting and stuff.
Absolutely. What about respiratory illness? They're breathing in a lot of stuff. Right? So know the So know these 8 particular common health issues. Okay, please. Okay. Is that distracting? I don't know what's going on outside my window. Levels of prevention. Okay, here we go. Okay, this is levels of prevention related to rural health. Easy peasy. Primary, teach workers how to reduce exposure. Right? Anybody argue with that? Secondary, conduct screening such as urine testing for pesticide exposure. Anybody have an issue with that? And then tertiary, initiate the treatment for the symptoms of pesticide exposure. So they have pesticide exposure. Now you have to help treat it. Okay. Pretty straightforward. Okay. Next is barriers. What are the barriers to healthcare in rural areas? You can have a look at this, page 380. We need to know this because there are a lot of barriers. We've already talked about some of them. But please read through the list. Unavailable public transportation, lack of personal transportation, unavailable outreach services. What about the addictions? I don't think they have rehabilitation centers in rural communities. You have to travel long and far to get to them, right? Unpredictable weather, travel conditions, right? Maybe inadequate or insensitive provider attitudes that don't understand what rural populations are all about, their values, beliefs. Language barriers, huge. Think about migrant farm workers, language barriers, right? You might be dealing with numerous different cultures at one time, right? And then for those types of groups, care and services may not be culturally and linguistically appropriate. So lots of barriers, lots of challenges. Okay, so here, our insights, our knowledge about rural populations is important. Okay, we can't have a demeaning attitude, we need to be educated about rural populations. We can't be insensitive. We're going to have difficulty relating to the clients, right? And insensitivity generates mistrust. And what are we trying to gather first and foremost with all our relationships? Trust, right? Trust becomes even more of a challenge in rural because a lot of them want to just stay private, keep private, don't want to open up, talk about what's going on, right? So you've got to be able to establish some sense of trust. Okay, so we play an important role. We play a really important role in developing community health programs that are available, accessible, affordable, appropriate for what the needs are, right? We design strategies to implement. This is all about, right here, this is all about our ADPI. This is how we're applying our ADPI in the rural community. Right? Identifying what the needs are, doing an assessment, right? Doing some planning, doing some implementing of programs, and then evaluating them to see if they've met the needs of your rural clients. This is interesting, nothing to memorize, or you'll be not tested on this, but very interesting. In table 22.1, it gives certain different aggregates of the population: farmers, ranchers, Native Americans, African Americans, migrant farm workers, and it talks about what each specific group's healthcare needs might be. And then it goes over what are the health risks and maybe conditions that they may come upon. So just interesting, just wanted to point that out to you. Okay, there's some, this chapter talks about immigrants and migrants. There are mostly similarities of these two groups, but we speak about migrant families as having much more stressful environment, very unpredictable. They may be moving around a lot, right? And so some of the issues they deal with are housing, migrant, they may have poor and unsanitary working conditions, right? Making them more susceptible to health issues. Okay. Children of migrant workers, they are very, very at risk, right? These migrant farm workers, parents want a better future for their kids. It's a strong catalyst for bringing them. Often the migrants are here with their whole families, right? Children lack a lot here. They may lack immunizations. They may lack proper nutrition, maybe more susceptible to infectious diseases. Okay, lack of dental care, pesticide exposure. Children of migrant workers are very, very high risk. And in some cases, it's even difficult to determine the age of these kids, right? So some cultural considerations in migrant healthcare, first and foremost, our nurse-client relationship. Okay, we have to exhibit trust. Can you guys hear that in the background? Is it distracting? If you guys can't hear it, I'm down with
No.
that. That's great. But for me, it's driving me nuts. I think our road is getting paved today, of course. Nurse-client relationship. There's a nice section here about the Mexican population, which I want you to read about right here. Okay, it's on page 385. Okay. So I want you to read this section about the nurse-client relationship and why we single out the Mexican population, because they have very specific values and beliefs that you should know about to understand how to develop a relationship with them. Okay. And here's your QSIN box. Remember, your QSIN is your quality and safety education. Okay. And each chapter goes over a different competency. Okay. This competency is patient-centered care. And go through this. It gives you a nice client-centered care question to ponder on this chapter, focusing on the competency of patient-centered care. Here's your case study. I've provided you with the answers to the case study, right? And when I sent out your PowerPoints, this is an excellent additional, you know how I feel about case studies. I love case studies. They're actual real life scenarios that you get to answer questions to. The rationales tell you why you got the right answer and why you got the wrong answer, or why the answer you chose is wrong. So if this is just an additional resource for you in each chapter to do, the case studies I find extremely helpful. Okay. This next box I want to cover, characteristics of nursing practice. All right, what do we need? What tools do we need? Well, in rural nursing, we need to bring the whole toolbox, right? Okay, you might be an OB nurse, you might be a pediatric nurse, you might be a school nurse, you might be the immunization nurse, you might be the wound nurse, you might be the education nurse, right? Rural, you bring everything. You're probably the only one, and your closest contact to even get a second opinion may be 2 hours away, so it's a phone call, right? That's what rural nursing is all about. Okay, so again, to have a look at this list, you need a variety and diversity in clinical experiences. You may be taking care of clients all the way across the lifespan. Okay, you may be taking care of, you will be taking care of infants, brand new babies, all the way up to death and dying. Okay. So make sure you can answer a question about characteristics of nursing practice. There's your lack of anonymity. Okay, you may be there's a story in this chapter about a nurse. I don't know what she works in several areas in the community. She's in the schools, she's in the clinic, so when she goes to the grocery store, she sees everybody she sees, she knows, but they all know her from a different section in the community. So for her, there's absolutely no anonymity. Make sense? Exposure to clients with a full range of conditions and diagnoses. Okay. Okay. Healthy People 2020, have a look at this. This is your Healthy People 2020 box. Remember, I'm just going to give you a pointer from exam 1. Lots of people got Healthy People 2020 questions incorrect. Tell me how you're supposed to answer Healthy People 2020 questions when they come up on the exam. What if all the answers look good? How do we communicate based on Healthy People 2020? What is the best way to communicate with new parents? Positive parenting skills, nutrition, reproductive, exercise. How do we know, which answer, what's the only answer that's correct? Positive parenting skills, correct, because Catherine, that was in the 2020, that was in the box in that chapter. All the other answers are great. Yes, we want to have those discussions with the parents. Reproductive, going forward, nutrition, follow-up appointments. Yeah, of course, that's all great. But they're not Healthy People 2020. I can't stress that enough. Put these goals and objectives on an index card. There were a couple of questions that all the answers were awesome. They're great. We want to do all of them, but only one was in Healthy People 2020. Okay, so please don't get caught up in these Healthy People 2020 questions. Just because an answer looks good doesn't mean it's the right answer. It has to be part of Healthy People 2020 specifically. Okay, this is a good one. It's not highlighted, so nothing to memorize for an exam, but this is an excellent box on how to build professional community and client partnerships. Okay, page 388. Okay, that is our rural health chapter. Anybody have any questions? Do you have a little bit better of an understanding of rural population, migrant population? Okay, let's move into chapter 23. Poverty. We're selecting 4 incredibly vulnerable populations. Poverty, homelessness, teen pregnancy, and mental illness. And we'll go through each of them. Okay. Again, your chapter outline, your PowerPoint is this. Your chapter outline follows it exactly along. Okay. And then your objectives. Have a look at your objectives. Remember, if you haven't looked at the PowerPoints, and this is all brand new information for you. So you've got to follow along and look at the objectives. And I try and pull my teaching points out of the objectives. That's what we need to cover, because that's what you need to be competent in after each chapter, is being able to articulate these objectives. Okay. So our 4 groups who represent members of a large percentage of vulnerable populations: the poor, the homeless, teen pregnancies, and those who are mentally ill. Okay. This is, I want everybody to read through this. Okay. Or let's read through this together, right? With these particular populations, we have to examine our own beliefs, right? Our own value systems. And we need to be knowledgeable about these vulnerable groups, right? So let's say you are doing a health screening in a homeless shelter. Somebody asks you for money for bus fare. What do? Do you give it? Do you not? When you visit a home of an older adult whose kitchen is covered in roaches, what do you do? What are you obligated to do? Where do you sit if they offer you a chair? What if you're making a visit to an extremely unclean home? What do you do if they offer you food? Okay. When I worked with high schoolers in school nursing for years, What do you do if student comes into the health room and says, I need to know where to get an abortion? What do you do? Right? Or I'm pregnant. What do I do? Where do I start? So we need to be able to check our own practices, check our own beliefs, check our own values with regards to these populations, right? Nurses' behaviors in these situations with any of these groups, right? Our behaviors influence the relationship that is developed. And this is already a real tough population to crack anyway, right? With regards to trust and open communication and gathering information. These are already real hard populations to work with. So you need to be really, really careful in how you are presenting yourself, right? We need to be able to value individuals, promote health, respect. We want to respect and try and restore human dignity. Okay, these people are suffering. They're suffering a lot, right? We want to help them improve the quality of their life, their families' lives. Okay. Not all are willing to embrace the resources and help we offer, but it's a lot of people that will by just simply reaching out. And that's a big job of the community nurse. Okay. And before I forget to mention, most of the vulnerable population papers come in on these 4 topics. Right? The homelessness, the mentally ill, substance abuse is another common one. Yeah. So, and it's because you guys, students, want to explore these different vulnerable populations in your own community, right? Once we start having conflicts with these conflicts of beliefs or with these groups, it's an uphill battle from there. Right? We're dealing with different social backgrounds, different cultural backgrounds, different economic backgrounds. I mean, who knows? Who knows why they're in the situation they're in? Okay. First one is poverty. You know, we have already said that poverty is the defining factor in functioning, right? For individuals, families, communities. If you're an individual living in poverty, with a family, everything's going to be off kilter. Housing, food, education, insurance, healthcare, right? So that is definitely plays a huge factor, poverty. And then there's lots of different programs to support families living in poverty. What's happened over the last 2 years? I've never seen anything like it in the school setting. You know, numerous families above the poverty line. Something happened with COVID. They lost their job. They had to stay home. They got laid off. Everybody was on lockdown, right? The income dried up. I've never seen so many young families go into poverty, become homeless with kids, young kids. It's tragic. I mean, that's all starting to get better now, but during that first initial year it was horrible. It was horrible. I mean, we all know, I'm sure, I know somebody in every one of these 4 groups. And you probably do too. Family member, coworker, friend's kids. Every one of these, I can name one person, more than one person in each of these. We all are exposed to it. Right? We're all exposed to it as citizens, but then we as nurses, you as 2 new
And
almost nurses. What?
nursing students are in the vulnerable population, I feel too,
Yeah.
lack of work,
Yeah.
overstudied, things like that.
I agree. Check. What are some causes of poverty? Here's some causes. I mean, we don't need to memorize these, but just have a look at this list. I mean, so many reasons. This is just the starting list. Okay. And how does poverty affect, what are the effects across the lifespan? right? In poverty, you're have less access to healthcare, so you're probably going to have more chronic diseases. Okay, higher infant morbidity and mortality, shorter life expectancy, definitely more complex health problems because you're not getting the care you need. Chronic diseases, we talked about, hospitalization rates are greater when you're in poverty because you don't go and seek out the preventative, the primary or the secondary care. And then box 23.1, look at the effects of poverty on health of children, right? Have a look at that. We're on page 395. Please know this or know, be able to identify effects on children that poverty has. Really, really tough situation for these kids, right? One of the things they talk about, I think it's in the homeless section, is how each kid is affected, how an elementary kid or a middle school kid or a high school, they're all affected differently when a family is homeless. So the second one is homelessness. How do you even understand the concept of homelessness? Okay. Think about some of these questions. What do you think it's like to live on the streets? I know people that have lived on the streets. So do you. All right. What issues might confront a young mother and her children inside a homeless shelter? How are, I often think, how are people so poor that they have no place to go? They are. What really causes homelessness? Right? How do you respond to somebody on the street asking you for money? What if it's a young mother with young kids asking you for money? I mean, I don't know I know where you guys live, but where I live, on every street corner, there are people there, right? Every street corner, every light. A lot of it is young moms with young kids standing there in the freezing cold or the rain or the snow, right? How do you feel about that? And then here's a starting list of homeless people and the following health problems they may present to you with. Hypothermia, we know why. Infestations, hypertension, diabetes, TB, HIV, trauma, mental illness, and then certainly the increased use of tobacco, alcohol, and drugs. This is how they may present to you, page 397. Then you guys can have a look at this, your healthy people objectives related to this chapter: poor, homeless, teen pregnancies, mental illness. Okay. Here's our 6 goals. And then this is a really good summary of homelessness. Through page 398, have a look at this, right? This is where it talks about how being homeless what are the effects across the lifespan? Okay, what if you're homeless when you're pregnant? What if you're homeless with toddlers? What if you're homeless with teenage kids? Everybody has different needs, right? Nurses, we need to be aware of the unique needs of homeless clients at every age. And this goes through what the general risks are at each age. So have a look at that. Okay. Okay, this next one is teen pregnancy, trends in adolescent sexual behavior in pregnancy. Teen pregnancy, really, really a vulnerable population, right? Why do we think that they have such teen pregnancy is a public health concern? Because of its significant impact on the community. Why are teen pregnancies, why are they so impactful in the community? Why are they typically using up a lot of the resources in the community? Well, they tend to not seek prenatal care. Therefore, they tend to have maybe low birth weight babies that may end up in the hospital. They're uneducated. They may need lots of parental teaching, coaching, right? Racial and ethnic minority groups have the highest rate of teen pregnancy. Okay, let's look at some. So, another factor about teenage pregnancy is the history of sexual victimization. Okay, family structure, parental behaviors can influence teen pregnancy. The pregnant teens are more likely to have been sexually abused during their lifetime, with rates recorded as high as 60 to 70% of teen pregnant girls having been previously sexually abused. Right? Adolescent girls with a history of sex abuse for early initiation of sex, right? They're not using birth control. They're more likely to use alcohol and drugs, right? They're more likely to have older sex partners. I mean, we have a district so big that I retired from that we actually have a school. We have a particular school that houses all of the pregnant high schoolers and some middle schoolers, and that their school curriculum is focused on academics, but also making sure they're taken care of. Right? And then young men and paternity, that has its whole sets of issues as well. And then you may be faced with conversations with teen pregnancy, with teenagers who are pregnant with regards to abortion services or adoption services. You need to be aware of the resources in your community for both. And then know that teenagers that are pregnant are definitely considered high risk OB, right? For many reasons: nutrition, lack of prenatal care, lack of education, really just kind of lack of understanding of what's going on, right? So they are considered high risk. Okay. And then we know that teenagers who are pregnant are much more likely to experience violence during their pregnancies, more so than adult women. Age definitely is a factor. It makes them more vulnerable. Okay. And then violence, we know in teen pregnancy has been associated with substance abuse, poor compliance with prenatal care, poor birth outcome. Okay. It's hard. It's hard to, what if you're working in a clinic and you are the community nurse, public health nurse that's going to have this first meeting with this teenage pregnant girl that has absolutely no clue what's going on. How do you begin that conversation? Right? How do you get information about health history? Right? One of the things that, since violence is so prevalent in teen pregnancy, one of the things you should be asking at every single visit is about violence. Right? You need to ask about violence at every visit. Yes, they may not be abused in their first trimester, but maybe they are in their second when she's showing, or her third. Maybe she's being abused by the young teenage boy, who knows? Right? But frequent routine assessments are necessary. Okay. Just because they say there's no violence at their first visit doesn't mean there's not going to be violence at their second visit. Violence is huge with teen pregnancy. So you got to cover the bases there. Okay. And then this is really important too. One of the things that we need to be aware of is how do we observe, what things do we observe with a mom and a baby that should be happening? Are they bonding? Are they trying to meet the needs of the baby? Do they need some education on, a couple things in here? Babies often enjoy when you sing to them. Okay, do they play with their baby when the baby's awake? Do they attend to the needs of the baby when the baby's crying, or try and figure out what's going on? Are they hungry? Do they need a diaper change? Right? So have a look at this list. These are healthy. This is what we want to be seeing. Okay. So this how-to box is the following the suggestions that nurses can make to teen moms. Okay. All right, mental illness, huge, 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 right? Huge issue, right? We have mental illness in 4 different areas, okay? We have at-risk populations for mental illness, 4 of them, children and adolescents. And I can tell you from being in the schools that the increase in mental illness with kids and adolescents is off the charts. Never seen it in 20 years like it is the last couple of years. Never seen it. Younger and younger and younger. Preschool. Okay, and then adults have their own issues, right? Stress, right? Multiple role responsibilities, job insecurities, maybe unstable relationships. Lots of things cause mental illness in adults. And then we have adults with serious mental illness. Okay. Right, that could be your homeless population. Homeless population tends to have a lot more serious mental health issues. Right, people that are incarcerated. Okay, here's your case study that I sent you the answers to. This is actually a really good case study. If you would like an additional activity to just practice and increase your knowledge. And then your older adults. Okay. And your older adults and what kind of mental health issues they have. Okay. A lot of issues with substance abuse with this population. Right. A lot of issues with depression, a lot of issues with dementia related behaviors. Right. So just know that these are your four vulnerable populations that this chapter discusses. I already printed this out. This is great. Put it in your fridge if you need it, or in your book somewhere. I use this for friends and family. It's just an excellent resource list. It's on 409. Okay. Examples of sources of information and help for people with mental illness, mental health problems. But this is a lot more than that as well. Given parents in the schools, lots of parents, this attention deficit information network. Right? Given Parents Bipolar Support Alliance. It's a great resource to have. Okay. Levels of prevention, right? We need to understand what the levels of prevention are related to poverty, homelessness, teen pregnancy, and mental illness. They look different with each one. Okay, so here's an excellent box in this chapter 410 of levels of prevention related to mental health. Please read through this. It has numerous examples, numerous bullets. Okay, if you're not understanding why each of these is in each category, then we need to get together and we need to review it. Okay, so please have a look at that, page 410. Okay. And there's your CUSIN box. The competency in this chapter is client-centered care. Right? And I love this question, client-centered care question. Self-awareness is the key component to providing authentic, genuine client care. Remember, these are nursing competencies we need to have. Okay? So what they're trying to educate us on here is when we're providing client-centered care, we need to have a self-awareness that is genuine and is focused on the client. Okay, and it gives you some questions to ponder. What do you really believe about is true about being poor? What do you personally know about being poor? Have you ever been personally poor? How does the media play into this? Okay, so CUSIN is just there's nothing to memorize from any CUSIN boxes. I just want to get you in the habit of knowing what these 6 competencies are, and it's reviewed, a different one is reviewed every chapter. Really good information. Okay. Okay, I think the last thing was, sorry. We don't need to review that. That was it. So a little bit more detail of those 4 populations. And then we'll get through this chapter. I'm going to go through this one pretty quickly because we're going to then talk about the faith community nursing and the home health and hospice nurses. Okay, so this kind of goes along with what we've been talking about. Vulnerable populations, very susceptible to alcohol, tobacco, and other drug problems. Okay, you go through your chapter outline. Okay, we're going to go through it in the book. This chapter mainly breaks down what kind of substances are abused, breaks it down into psychoactive drugs, illicit drugs. Okay. Talks about predisposing factors. We'll go through it. So here's your objectives highlighted. Please take a look at those and be mindful when you're reviewing your chapter. The chapters don't need to be read from the first word to the last word. Okay. Be mindful of what's in your objectives. That's what you should be focused on. Okay. Does that make sense? Okay. Substance abuse, leading national healthcare problem, more deaths and illnesses and disabilities than any other health condition. Right? We know that there's considerable death and disability caused by the use of tobacco, alcohol, and other illicit drugs. I just read a story in the last couple of days that 2021 was the highest number of overdoses, right? It just keeps getting worse and worse and worse and worse. Right? Substance abuse affects everybody, affects all ages, races, sexes, career paths, doctors, nurses, CEOs, poverty, families in poverty, billionaires and trillionaires. Okay? Affects everybody. And there's every one of us knows somebody who has an addiction problem, or knows somebody who had, or is going through something right now. It's everywhere. Okay. We talked about the scope of the problem. So then they go through and talk about the drugs. What are some psychoactive drugs? Okay. I'm not going to go through all these. I just really want you to know about the categories. Okay. Categories of psychoactive drugs that are abused. They can include depressants and stimulants, and alcohol. Obviously, alcohol is abused. They've mentioned tobacco, right? Tobacco being the foremost preventable cause of death. Okay, $300 billion a year in healthcare costs related to tobacco. It's mind-blowing. How can you get in there and talk in the community and talk to kids about the dangers of smoking? Caffeine. One of the most common, widely used psychoactive drugs in the world. Of course, I started looking at this going, oh my gosh, I drink tea all the time. How much caffeine does it have in it? So this is a good caffeine content in some commonly used substances. I once drank a Red Bull. I don't think my heart stopped palpitating for 3 days. Okay, I couldn't handle it. I drink tea all the time, but I try and drink as much decaf tea as possible. I've now, since I'm a chocolate junkie, I've now based on this, switch to dark chocolate. I mean, switch to milk chocolate from dark chocolate, because all I ate was dark chocolate. Now I'm having to go to milk chocolate from reading this. It's just amazing how much caffeine is in some of these things. One of my kids drinks like a Monster, like every morning on the way to work. It's like, oh, blah, whatever. And then your illicit drug use, your opioids. Okay, we know that there's an extreme epidemic in the United States, right? Overdoses, poisonings. I mean, just huge. It's just really sad. Heroin is one of the most common opioids, right? Cocaine, amphetamines and methamphetamines. And then marijuana. Where are we at with marijuana? Lots of states are legalizing it, but it does come with its issues. Right? And they say that here, one of the greatest physical concerns for chronic users of marijuana is the possible damage to the respiratory tract from smoking the drug. You know, we here in Colorado are one of the first to go, where do we go? Legal. Wow, you can find out here, there's a smoke shop, or what do you call them? Smoke shop. Anywhere you look.
A dispensary?
Dispensary. They're everywhere. Everywhere. Okay. And you can become dependent on marijuana as well, just like alcohol and other drugs. And then they talk about street drugs. Okay. What are some predisposing factors? Okay. There's genetics. Okay. There's definitely genetics, dependence on alcohol and other drugs. Dependence on alcohol and drugs often co-occurs, right? Right. There's evidence indicates that both disorders are at least partially genetic. Okay. This is the chapter. Is this the chapter? Yep. Okay. So this is where I want you to start when you go through the rest of this chapter. Page 422. This is the best description in the whole book. You're going to get a lengthy, detailed description of, I know it's related to alcohol, tobacco, and other drugs, but this is an excellent description of primary, secondary, and tertiary. Okay. It's lengthy, but it's worth the read. Okay. So they're talking about harm reduction as a primary prevention, but everything that's covered between primary and secondary is in primary, and so on. Let me show you. So primary prevention and the role of the nurse. Okay, so everything here, it's all primary. How to set up a community-based activities aimed at prevention. How do you do drug education? That's primary. How to determine that determine the relative safety of a drug for personal client use. Prevention, primary. And this box is in the middle of the primary prevention section, but please take a look at it. It's on 424. Okay, as is the QSIN. And then we get to secondary. So everything above this secondary is all giving you examples of what primary prevention activities there are. And then secondary. Okay, how do we assess? Right? Early screening. How do we screen? How do we early identify? Okay. How do we do an assessment of socioeconomic problems resulting in substance abuse? Screening. What do we do? Okay. Drug testing, right? That's secondary. Who are the high risk groups? And it goes through a few groups. Healthy people is found in the secondary. They just have to, they're putting the boxes in different parts of the chapter, but Healthy People 2020 is found in the secondary section. And your older adults, your injection drug users, these are all high risk groups. right? So we're screening these groups. That's why they're in the secondary section. Drug use during pregnancy, use of illicit drugs, codependency. Okay, those are all the things we assess, right? In secondary, remember, early identification, early treatment. Okay, we don't want to let them get to a tertiary level, right? And so what do we do in tertiary? They already have the dependency, the addiction, whatever. We look at detox, right? Addiction treatment, smoking cessation programs, support groups. Okay, so those are all examples of tertiary, right? So I know that's lengthy, but it really breaks down why these activities are in what those three levels. Does that make sense? I want to take a moment to explain that to you. I found that to be extremely helpful. It's tough. What's our role? What's the nurse's role in substance abuse and addiction? Right? There's again, supportive, compassionate, kind. You're trying to establish trust, right? And there's your practice application. This is a good one. I've provided you the answers to it, so you don't have to go to Evolve. It's on page 430. If you have a minute, do this practice application. It's a really good one. Got lots of good feedback in previous terms from students that did it. Okay. So that's a few tough chapters to go through. Anybody have any comments? Before we move into the happy chapter of what does it mean to be a parish nurse? So anyway, those are three tough chapters to go through. I realize it. Lots of stressful situations with rural migrants, those 4 vulnerable populations, and then talking about abuse, alcohol, tobacco, and other drug abuse. Those are tough. It's tough chapters. Okay. But if you're a community nurse, you will be working with families, individuals with those issues. Okay, so let's move on to a happier topic. Okay, does anybody know a faith community nurse or a parish nurse? I had a student in my class yesterday who had an aunt who was a parish nurse, and she described she could have taught this chapter. So does anybody know anybody that works in a parish or is a parish nurse? It's a pretty cool job to have. Okay, what do you think of when you think of faith community nurses? What's the first thing that comes to your mind? Anybody? Do you think it involves spiritual support? All right, you guys are quiet this morning. There's your objectives. Hopefully I'm covering those objectives. That's my goal. Okay. So after each class is over, you should go back to those objectives to say, can I answer all these questions? And if I can't, I need to go find that section in the book and reread. Okay. So the first thing we need to know is what is the difference, 2 definitions. What's the difference between religiosity and spirituality? Page 511. Let me preface this by saying that when we talk about a faith-based nurse, it's whatever faith you practice. Okay? We could be, and wherever you practice. We could be in a church, we could be in a mosque, we could be in a cathedral, we could, wherever. Okay, all different kinds of religion, Baptist, Muslim, Catholics, Episcopalians, Lutheran, okay, whatever is your belief. So that's what religiosity is. So religiosity is your belief, your religious belief. Okay, it's associated with a specific religion or religious tradition or denomination. When you think of spirituality, that's the big picture, right? What are your attitudes and beliefs related to, say, God? Okay, so that's your big picture. Okay, where religiosity focuses on your primary religion in your denomination. That's the first thing we have to know. Okay, faith community nursing can faith community nurses can be also called parish nurses. Okay, that's a pretty common terminology of faith communities, parish nursing. We know that in our faith communities, we have health ministries, right? Every religious organization has health ministries. What are they? Right? They're activities and programs in your faith community, whatever it is, right? Organized around health and healing, right? To promote the wholeness and health across the lifespan. That's what health ministries are. They may be, or here's some examples. They may be support groups. They may be grief support groups. They may be quilting classes. They may be prayer and healing services. Whatever your whatever your religious organization decides what kind of ministries they want. What are the goals of their what are the goals of their ministry or of their faith community? We need to know this. We need to know that's actually your first attestation question. There's two parish models, okay? Box 29.1, we need to know the difference, okay? There's a congregation-based model. Pretty simple. You are working within only the congregation. Okay, so the nurse is accountable to the congregation and its governing body. Okay. However, if you broaden that perspective, then we have institutional-based model. Okay, which this includes your collaboration and partnerships in the community, right? The nurse may be in a contractual relationships with hospitals, medical centers, long-term care establishments. So you're partnering with the community to provide services. So if your church decides that they want to make sure they provide a full service of services to the elderly patients that are coming home from the hospital after a stroke. Well, the faith-based nurse may not be doing all that. She may be just kind of coordinating getting the patient home. So they would contract maybe with PT and OT and those kinds of services. That makes sense. So that's a difference. Congregation based is within only the congregation. You're responsible only to the congregation. Institution is you're branched out and now started developing partnerships and collaborating with other agencies, if you will, other services in the community. Okay. Okay, the big difference with the faith community nursing practice is the spiritual dimension. Okay, so that's what the addition. The spiritual dimension is central to the practice of parish nursing, right? Nursing embodies the physical, psychological, social, and spiritual dimensions. Okay, so that's the addition. They bring the spiritual dimension. Okay. Here's our levels of prevention. This is a really, really, really good box. Look at all the examples you're given. Okay. Here these are related to overweight, obesity, and physical activity. Okay. Have a look at please have a look at this box, 516. Many, many examples of each. Okay. If you're not understanding primary, secondary, tertiary, up to this point, we do need to do some kind of a tutoring session because you should have a really good understanding by this point. Okay, so I want you to read that on your own. If you're not understanding it, I need you to reach out. Okay. One of the big responsibilities that are put on faith parish nurses is maternal child health. They're usually very involved with maternal and infant health. Okay, they're the nurses that are typically going out and doing family visits for new babies, right? And what are they looking for? Again, they want to assess parenting skills. They want to assess parent-infant bonding. Reinforce the holistic reflection of life transitions, plan for faith community support, right? How do we bring faith into this new family? They may also do community prenatal classes or facilitate classes within the faith community, right? Prenatal classes, postnatal classes, right? They may facilitate support groups that reinforce positive health during pregnancy. Okay, so they're very involved with maternal and infant health. Okay. And then as we start to talk about the different roles of nurses, we've already done school nursing, but here we're doing faith. And then next chapter, we'll do hospice and home health. And then later on, we'll do occupational. There are always going to be issues. Okay. Always going to be issues in all these kinds of nursing. There's going to be professional issues. It's going to be 4 kinds of issues that we address with all these different kinds of nurses. Professional issues, ethical issues, legal issues, and financial issues. It's going to come up in every chapter of these 4 types of nurses. Okay. And that's what I need you to know is what kind of issues will come up. Okay. With ethics, think of faith-based community nursing. What about end-of-life care? What about DNRs versus not being a DNR? What if a family member wants something that the other family, the ill family member didn't want? Right? Lots of issues come up. Okay, and then there's legal issues, financial issues. Okay, and then here's your Healthy People 2020. Okay. Objectives related to nutrition and weight and physical activity and fitness for youth in your faith communities. Okay. I think that is all. There's your QSIN box. The quality improvement is the competency of this chapter.
Pardon me, sorry to interrupt. Can you go back up to the issues part? I just want to see the highlighted sections.
Yeah, the four different kinds of issues.
That was a lot of issues, and I like to know my issues.
So, issues in faith community nursing practice. You're going to have professional issues. Is that what you're wanting, Andres?
Yep.
Ethical issues, legal issues, and financial issues.
Gotcha.
Those are going to be across the board. Okay. So that's it for faith community. That's what I wanted to pull out of that chapter. Okay. Do you have a better understanding of what a faith community nurse does? Okay. And then the last chapter I want to go through is the nurse and home health and hospice. Okay. They're presented together in this chapter. So let's go through that. Okay. Here is your second question in your attestation. If you don't want to do your attestation today, second question is, what are your practice models for home health, or excuse me, for home health? Okay, so we'll cover those, but this is the answer right here to your second question. Okay, so your objectives should be able to do this, articulate this when you're done. So let's go. This I'm going to have you read. This is a really good summary on home health care. I'm just going to read a little bit of it, but I'd like for you guys to read through this. It's page 525. It's just an excellent overview of home health care, right? We'll start. home health care, we know includes disease prevention, health promotion, and then episodic illness care, right? And where are we doing home health? It's places of residence. This could be a house, apartment, trailer. It could be a car. It could be a shelter, right? It's where somebody lives. Could be in residential facilities with the elderly. Okay. We know that the optimum place, optimum location for certain healthcare is in the home, right? Such as hospice services, home visits by public health nurses, right? And then when we're taking care of clients in the home, we're also taking care of families, right? We may be teaching families how to give injections or how to give medications or how to change dressings, right? And our levels of prevention comes up quickly in this chapter. It's applied to home care. Okay, primary, the nurse administers the seasonal flu vaccines. Prevention, right? Secondary, when you're in the home, the nurse monitors the clients in their homes for early signs of other new problems, right? You're screening for other new things going on, right? Tertiary. Okay. Nurse provides instructions about daily dietary modifications and insulin injections to the newly diagnosed diabetic patients. Okay. We don't need to go through the history. And then here's your practice models. Okay. And here they are. I have all this highlighted. I don't know why. What I need you to know is what the practice models are and a simple explanation of each of them. So population-focused home care is focusing on a certain population, your diabetics, your infants, your kids, your substance abusers, your homelessness. That's population-focused. You're focused on a certain population. Okay. Second is transitional care. These are your practice models. Clients are going from one place to another. Maybe they're going from home to the emergency room. Maybe they're going from assisted living to long-term care. They're going from the hospital to the rehab center home. So there's a transitional care. Home-based primary care. They typically call these the house calls. Okay. These are when clients cannot get to their medical provider. They can't get to the clinic. They can't get to the community center because of issues. There's barriers. They can't get there. So the primary care is provided in the home. Okay. And then the fourth is home health, right? Home health agencies are divided into 5 categories. You don't need to know all that. You just need to know that home health is one of the 5 practice models. Okay. And then this 5th one is hospice. Okay. And here's where we introduce hospice. What is hospice? Palliative care. Palliative care of the very ill and dying. What are we trying to accomplish? We're trying to help reduce distress from physical, emotional, and spiritual symptoms. So those are your 5 practice models. So I just need you to know that there are 5 practice models and what each one of them represents. And I kind of went crazy with my highlighter, didn't I? Okay. This is good. This is this how-to box on page 529 is an excellent summary of hospice. Hospice approach to care in any setting. Okay. And we all probably know somebody who is either in hospice or has been in hospice. Hospice nurses are rock stars. The hospice nurses I've worked with, rock stars. They're able to not only work with the client, it requires additional education and training and certifications, but they are able to work with the entire family. They're able to pull family members in who don't want to be there, right? Because we know that one of the things in hospice care is we want everybody participating, right? They are so knowledgeable and so well versed at working with the whole family unit. It really is incredible. So please have a read about 529, the how-to box. Excellent, excellent box. And then you also, part of hospice is the home care of a dying child. Tough stuff. You know, I had a good handful of kids that over the years that I followed from elementary school to middle school to high school that eventually with their really chronic severe conditions went into hospice. I've been working with the parents for years and years with these kids, taking care of them in the school setting. Really tough, tough, tough. But we need to be prepared if we are a hospice nurse in the community that we potentially are working with families of a dying child. Okay. Why do I have all this highlighted? Silly me. Look at all the roles in home health, hospice, and palliative care that we may fulfill. Okay. Hey, if we're working in the rural communities, we may be doing every single one of these, right? But look at all the roles that we fulfill. Clinician, which would be direct care, case manager, right? We're organizing all the services, advocating for our clients, maybe teaching the clients about medications they're on and side effects, teaching the families, right? So and then this highlighted section just goes through what each of these mean. So if you want a little bit more detail, it's all right here underneath. Okay. And then it talks about professional development, you know, education in these roles, what kind of education to be a hospice nurse it requires. You know, nurses come to home health and hospice for a variety of different educational and practice backgrounds. Okay. Home health and hospice nurses should be educated to function at a very high level of competency, right? So they can be relied upon not only by their peers, but also by the community. Okay. Anyway, that's accountability and quality management. Yep, that's important to talk about. We, as nurses, always want to practice the best evidence-based practice we can find, right? So quality improvement activities in these settings in the community are a very, very big part of how we deliver care, right? So with evidence-based practice, here's what in these settings, we would be monitoring the care. We would be looking for other opportunities to improve care. Okay, we're collecting data, we're making recommendations, we're implementing different activities that we've learned to enhance quality of care. Right, so there's not only evidence-based practice in the hospital setting, there's evidence-based practice in the community setting. We're always wanting to use the most current information that will help us provide the best quality care we can provide. And it's always changing. So we have to, as nurses, we have to stay on top of that. If you're a hospice nurse, you want to be staying on top of the best evidence-based research that we have for hospice care. I mean, think of how hospice care has evolved over the years. Think of how home health has evolved over the years. Think of how school nursing has evolved over the years. That's all based on research, evidence-based practice, right? And then Andres, here's your legal, ethical, financial aspects of home care. Okay, so it's in, just like we went through in faith community, there's
you.
those legal, right? I mean, Think of the ethical issues with hospice nurses. Probably a lot, right? So anyway, so that's it for home health and hospice. So that's a lot of stuff we covered today. Lot. How you feeling about everything? Overwhelming? Is it okay? What are you guys thinking?
Overwhelmed.
Yeah. But again, as you go back and review, please go back and review the highlighted areas. That information meets your objectives. Okay, so if you're following along, you don't need to read every chapter from start to finish. Okay, otherwise it's going to be way overwhelming.
They already seemed like we needed to read everything. I don't know.
What?
Highlighted? Everything was highlighted.
No, but as far as I need to take, I think I was pretty specific on what we need to know in that last chapter.
It was a bad joke. Sorry.
Oh, okay. Well, joke accepted.
Thank you.
I am going to go in and clean
I'll
it up
work
though.
on them. I'll work on them. Okay.
That's okay.
All right.
So I'm really trying to be very specific with you guys on what you really need to know. And I'm really trying to pull the information that supports the objectives. Okay. Let's go to our attestation real quick. Okay, let's go to week 4 attestation. First question is the difference between congregational and institutional faith community models. Remember what they are? With the congregational, who are we working with?
The congregation.
You are responsible to the congregation only. And you're institutional?
Basically, are you just working with everybody?
Yeah, you're partnering and collaborating with services in the community that your congregation has decided they want to try and provide. Right? Is it a PT service? Is it a home health agency? Is it an assisted living? Right? Because faith community nurses can't do everything. But if you're a large congregation and you want to branch out and provide all these other services, then you start practicing in the institution-based model, right? Because you're having to go find these services and contract with them in the community to meet the goals of your congregation.
Can I ask you something real quick?
You bet.
For the congregation, you're just basically working with what's going on within that church with their beliefs.
Well, with the community, with the congregation. So
Okay.
your home visits will only be to those, one of your jobs may be, please go do a home visit within the first week of new baby.
Mm-hmm.
Check in with the family, see what they need. How are they doing? Are they bonding? Are they using positive parenting skills? Right? Or maybe once a week, they've been asked, we have a congregation that seems to have a lot of suicides. So we would like for you to develop a support group for adolescents who might be at risk for suicide. We have a lot of big elderly population in our congregation, so they're dying. So we need grief support groups. Could you organize those for us? Does that make sense?
Mm-hmm.
Your whatever your congregation decides is priority within your congregation. It may be, like I said, large elderly population and they need company. I don't know, whatever's going on in your congregation. Does that help?
Mm-hmm. Yes.
Okay. So next question is your 5 practice models. What are they? Population focused. What's the next one?
Transitional care, home base, home health, and hospice.
Monica. Thank you. Thank you to Monica. Was that Monica?
Yes, that was me.
Yeah, good job. So did everybody hear, Monica, why don't you say that again? Population focused is number one, and then what?
Transitional care,
Yep.
home-based, home health.
Yep. Excellent. Thank you very much. Appreciate it. I'm speaking for everybody. They appreciate you. And then click submit and you're done. So what I would do once I get study guide 2 out to you, hopefully this week, what I would do when you have a minute, go back and review our notes from today. Okay, 2/3 of that study guide should be covered as of today, right? Weeks 3 and 4. And then whatever's not covered will be covered next week. Right? Same drill as exam 1. Please go through and look at the, well, what I'm saying, Addison, is the same drill as exam 1, meaning go through the study guide, make sure I've covered everything in those study guides. Okay. Or at least the topic has been introduced. Okay. Then if you need more information, go back to your book, go back to your PowerPoints, but you don't need to read the whole chapter. And then for goodness sakes, please try and attend a review session. Please make that a priority. And I know that deans are going to be bugging you to go to these because we kind of said, we didn't have great attendance, or I said that. So I said that, I'll own that. So what I say to the deans in my email is, hey, here's your at-risk reports. Would you please help support us getting students to the review sessions? So anyway, so that's all I have for today. I hope you guys have a wonderful rest of the week. It was snowing here in Denver yesterday.
What?
Not a lot, but I saw the white flags. It was awful. So anyway, I think it's supposed to get nicer today, but it sounds like it's still pretty, it looks like it's still pretty crappy out. Anyway, I would like to be someplace warm, but have to wait for summer for that. So does anybody have any questions? Nothing. You know where to find me. Reach out if you need anything. Okay, please, I'm available to you guys. I'm kind of disappointed that not a lot of people took advantage of all my time over the weekend, but that's your choice, right? I mean, this is a team approach. All I can do is offer up my time to help you guys, and some people took advantage of it. Most people didn't, but that's okay. That's okay. It's up to you, right? You're gonna get out of this class what you put into it. And my goal is to get every one of you across the finish line here in a couple of, what are we on, week 4? So got about 8 weeks left. It will fly. We're getting into the meat of this. We're really in the meat of this class now. Okay. So hope everybody has a great week. I'm going to give you 48 minus 12 minutes of the gift of time. How's that?
Thank you.
Okay. You guys reach out if you need anything. Have a great week. All right.
Bye.
All right. Bye.